Hey guys, we're almost in the home stretch. We got 4 more hours here. Aaron Geyer's going to take us through the next hour as the moderator. He's got a great group of panelists, one that'll be virtual. And Aaron, kick us off.
Thanks, Selene. Thanks for having us. So I had a great group of panelists here today. I'm going to share my screen here off and go through what we're. All right, so here we go. I got today. Our topic is going to be navigating stormy seas, which is basically about managing complications in surgery. And have 4 panelists with us today, and one is going to join virtually. I'm Parekh Family I'm the foot and ankle orthopedist at the clinic in the Panelists. We have with us Carroll Jones, who is at Orthopaedic and at the clinic in Memphis. Eddie Haupt at the Mayo Clinic in Jacksonville was not able to join us live today, but we do have a pre-recorded presentation by him. So the way we're going to run this is basically we thought that the best way to address complications, if you were to go through some cases that illustrate some of the and basically what factors to consider preoperatively to prevent complications, what strategies that can be utilized to address complications when they do occur, and what to consider next time so complications don't occur again. And I'm kicking off with a patient that I had in my practice over that it illustrates some of these points. So here's some of my disclosures, some of which are relevant to this talk. And here's the patient I'm going to talk about. I had a 67-year-old morbid obese patient, his BMI is 50, with poorly controlled diabetes, peripheral neuropathy, and a host of other medicals. He was at home. He was in South Georgia. He fell from a standing height when he lost balance. He's not a very active guy, just basically hangs out at home. So he walked on this swollen before to the ER. He just noticed it didn't look right. It swelled up and it was pointing the wrong way. So his x-rays revealed that his ankle had fractured and also subluxed. And they were out in a rural South Georgia hospital. They didn't have any orthopedic call cover. That hospital was splint, still displaced. He didn't have an open fracture, but the skin pretty well tented medially. You can see why on these x-rays is located, but that medial malleolus is really pushing on the medial skin. So this is over a week out when he did this. So I take him to the operating room. I fix him, and I was really concerned. He's a really big guy. He's diabetic. He's neuropathic, so he doesn't. Well, we need to add some extra hardware. As you can see, I put in 3 extra syndesmotics. Call this the ladder technique, thinking, hey, maybe this will help prevent him from having any issues. Well, I was still a little bit concerned about him because he had walked on it in a week. He definitely can't feel anything. He's a really big guy. And normally I'll have diabetic patients that I fix an ankle on come in a week for a splint change, check their wounds, make sure everything's going okay. For him, I said, I'm going to get him in at 5-6 days post-op just to make sure everything's okay. When he came in, he said, yeah, I haven't stayed off of it, doc. It feels a little different. I've been walking on it. So he comes in, and when he does, this is so the 3 screws I put to help hold it, those stayed intact, but it's as you can see, his plate 90 degrees. It failed. He dislocated the ankle. Malleolus was looking at us in the clinic. So I returned him to the OR since he has this open wound. Because of the significance there, I said, we really should just proceed to a hindfoot fusion. I'm not just going to try to fix the ankle. He's demonstrated that if we fix it, he's compliant with weight bearing neuropathic. We're going to do a hindfoot fusion. I decided to use the retrograde hammer nail rather than a hindfoot fusion nail made specifically for hindfoot fusion, given the fact that retrograde nails were the original way hindfoot fusions were done in the first place, and these rods are longer and larger in diameter, so I thought this would be much better fixation for this. So here's some intraoperative photos, actually, as we started to prep him, you can see there's a tibia looking out right through that medial wound. This is the actual plan. I removed it. I honestly have never done a plate that before in a patient. But our patients always surprised. So here's what he had. What we ended up doing, a revised fibula. I put a new fibula plate, try to buttress that side, put in this femoral rod all the way up to around the tibial tubercle, 3 screws distally, 2 locking at the top. I did prep his ankle joint too while we were in there to try to get it to fuse. So I keep him off of it 3 months, put him in a total contact cast, gets his wound healed. His x-rays start showing healing of the fibula, fusing of the ankle and subtalar joint. So at 3 months, I said, well, it's a little bit longer than I usually keep someone in a cast, but I think you're used enough that we can move step, which is a boot, and allow him to weight bear. And at 5 months, he was still looking good, so I prescribed diabetic shoes and orthotics. So at 6 months, a month later, he comes back. He's wearing Crocs. He said he never got the orthotics or shoes. He admits, I just never went and got them, even though I was fitted for them. And when I examined him, I'm a little concerned. He has a little bit of crepitus on the ankle when I stress the ankle joint. Looking at his x-rays, however, he's having fusion. As you can see in this x-ray, he's actually fused through osmosis. His fibular fracture looks healed. The lateral part of his ankle looks pretty well fused. He's got some lucency medially. Wow, this should be pretty solid. However, I was somewhat concerned because you can see if it's a little bit subtle, but if you look at the end of his rod on this lateral, it's now it definitely his ankle subsided some, and this rod is prominent. In addition, one of the locking screws here distally has backed out. It was not this far prominent laterally when we originally did it. However, I felt, this guy, I think he's fused enough. Let's move him to ordering a double upright with his diabetic shoe box. Maybe he'll actually get those. We can emphasize the importance of that, and so we proceed with that. So I get that for him, and then he gets his brace. He actually does get the brace about 3 or 4 weeks after we saw him. He comes back for his routine follow-up 2 months later. Yeah, doc, I got this sore on the medial part of my ankle. I think the brace was rubbing on me, but I really didn't think of it. I didn't call anybody. When we get him in the office, however, that ulcer, when we probe it, actually goes right onto the medial malleolus again. His x-rays did show some continued subsidence of the fuse. And so here's the x-rays at that point. I was also a little concerned that not only had the ankle subsided more, the rod was more prominent, the screws, now a couple of them are backing out, the more proximal one. And I saw this lucency also rod and at the front. So I'm given the open wound, this hurt change. I'm concerned, is he starting to develop not only a non-union, but an effective non-union given his ulcer? So given his other comorbidities, I'm very aggressive. I remove his from the ankle. IND, we saw his tail calcaneus, put antibiotics space in, IV antibiotics for 6 weeks with a PICC line, and we get him back in double upright brace adjusted so that no longer any rubbing there, and he progresses. But by about 2 months later, he gets another new medial ulcer, and the ankle starts to fall apart. You can see here, he's still got just union here. This space over here is much more loosened. So now I'm saying, yeah, he definitely has some concern about, some concern that this is effective non-union. You can also see screws from the lateral plate I left in that were not exposed to the ulcer in the first plate are starting to actually just fall. I've never seen this before either, where a screw just randomly is in another part of the foot. But again, this guy keeps surprising me. So I say to him, well, I think the ship is sunk. There's no point in me trying to go back and revise this. I really think that a below knee amputation is the best treatment option for you. But he and his wife are like, no way, I'm not getting an amputation. He also refuses any other further surgeries, including INDs. I said, okay, it's a crow walker. We can get him fitted for a crow walker. And for the last 3 years now, we've been following him. And what he basically does not very active guy. He's now in his 70s. Has intermittent ulcers. What happens is he'll do fine for a while, but if he does on his brace for a while, other ulcer on the medial side since he was in such a valgus deformity. And he comes in the clinic, he does wound care. The wound care center gets care of, comes in the clinic for follow-ups, and every time he comes in, I say, you probably need to know I'm doing fine. This is his most recent follow-up. I just saw him about a month ago. See, now another one of his screws had fallen out. This has actually been stable for about 2 years now. As one screw fell out, then the other one fell out. They just hanging out in the bottom part of his foot. But he is cruising along and has not been septic or sick or needed an amputation. Despite that, I think that would be his best option. So some of the things, so the takeaways, what I want to point out in this case, this is a complicated case, but I'll point out some of the things to consider, and this can illustrate. Preoperatively, even before I tried his ankle, we knew he was diabetic, I knew he was morbidly obese. I knew he had neuropathy given his presentation. At that point, one of the reasons I said, hey, I better put some extra hard iron when I fix his ankle, but obviously it wasn't enough. When we went on to the fusion procedure, also had to consider these fusion. You got to consider these factors because it's going to change exactly what you do for the fusion itself with both pre and post-operative planning. Non-compact, non-weight bearing also is a consideration to look at when you're considering fusion, as you may, you should consider keeping them off a bit longer and changing your post-op protocol. So initially, analyzing this case, there's a couple of things we tried to do I tried to address some of these concerns I had. One was the increased heart rate we talked about. I did see him sooner than I normally would for a diabetic. I was concerned about his weight bearing, and as you can see, that what I've done to prevent disaster. These are retroactively these things I've learned. Yeah, I probably should have maybe done this like this guy. If you noticed on my initial RIF X-rays, maybe I should have fixed his medial side. He definitely had an incompetent deltoid. I've repaired that. Should I have, since he's a morbidly obese pathic guy, should I have added increased immobilization, fixed even, or rather than splint after the surgery? Should I put in some Chance pin across the ankle temporarily just to hold, like we do sometimes with some unstable fractures? These are all some things that I think I probably should have done when I first fixed him. It would have, in retrospect, prevented him from bending his plate 90 degrees. In people with these comorbidities, when we go to a fusion, looking at it, one of the reasons I chose a more robust fixation femoral rod rather than the specifically designed hindfoot fusion nails, just because I felt this is a much more robust part. And for a guy that's this big, not thick, obviously will weight on it, I think this may help protect him. Longer, more robust immobilization. I did cast him 3 months, but maybe that wasn't long enough. Maybe I should have kept him off. Maybe I should have kept him in a cast longer than that. Maybe I should have got a CT scan. This is one thing looking back. Even though his X-rays looked good, it seemed like he was fusing laterally. He hadn't fused really. It wasn't enough. I should have got a CAT scan to demonstrate fusion before allowing him weight bear. Those are all considerations you may look at. We have issues, comorbidities, and trying to use. In diabetics like this, an A1C of 11 did. We were able to actually get that better with the primary care physician getting his hemoglobin A1C down to 5 was 9 months post-op. And so I think you have a active patient with these comorbidities that's undergoing a fusion or a total ankle replacement or something like that. You definitely want to get their hemoglobin A1C in a more reasonable range. In this particular guy, he was a fracture, so we didn't really have time to do that. But that is another big consideration, I think. In summary, I think key points to consider this demonstrate is that when you have a fusion that fails, like his did, we have to always consider, in fact, he's diabetic. He had an open ulcer that developed. He had some lucencies on X-ray. That should top of your list of things to consider in someone in this situation. Even in someone that doesn't have an open wound, the infection is or can be the number one reason for non-union. When you don't have when you do get an infection, you definitely should aggressively debride. Take anything that doesn't look good. Take and samples. Add antibiotics and use IV antibiotics for consult your infectious disease to help with this. Remove as much hardware as possible. This particular case, lateral side was okay and would provide a buttress, but maybe in retrospect I should move more. It's hard to say. And whenever you can consider revising a particular patient, say his fusion failed, was probably due to infection, there is the option we could have revised this. However, if you decide I'm going to go through another big revision to revise a failed ankle fusion, particularly in this situation, there's a lot of things you should. And in this guy, his diabetes is a big concern. His non-compliance with post-operative weight bearing and also his morbidity, I think, are all big things that you have to keep in mind. You say, I'm going to proceed with a big surgery. In this case, I felt that he was not a good candidate for revision given all these factors, and that a below knee amputation best. He decided not to do that, so he's just going along with brace and wound care. So that's hopefully we'll get some questions in on I think we're going to save some time at the end for each of the talks here today. So send those on the chat, and I will try to go through those at the end. But that is it for my talk, and I'm going to stop sharing here. We're going to move on to Jones here in a second. I'm going to turn it over to Carroll now, and he's going to take it away here.
Awesome. Great. Thank you. Yeah, that was a great case here. And I think these Charcot cases they always have so many chapters, and it's quite prevalent here in North Carolina as well. And there's a lot of discussion when we see these neuropathic fractures. Do you fix it like you fix it with the syndesmotic screw ladder, or do you just go straight to primary fusion? We kind of have that debate pretty regularly. Obviously, a lot of factors that help with that decision: the fracture pattern, how old is it, compliance, health of the patient, etc. I love the nail technique. Obviously, for the fusion, I usually just use the largest hindfoot nail, but the femoral nail is a great other alternative. We do a lot of frames with our nails for these people, particularly the guy you showed who's probably not going to be compliant. It's sort of a belts and suspenders approach. I don't know how much it changes the outcome, but it certainly makes us feel better. So anyway, that was a great case. So moving on to my case, this is a non-neuropathic ankle arthritis infusion case, and because this is complications seminar, I will, of course, this is going to come with some history here. So he's a 68-year-old, really delightful guy. I've gotten to be quite friendly with him over the last few years. He's a retired farmer. He lives about an hour outside of Charlotte. Loves hunting and loves golf. He's very active. Really doesn't have any significant medical history. If you talk to him just about his history over the years, he's always had these high arched cavus feet. As we've heard the story many times, with that, he's had many lateral ankle sprains over the years. He actually played basketball in college, and was quite an athlete at one point. So that was where things started with him. He underwent, ultimately in his 40s or so, he's now in his 60s, he underwent bilateral cavus reconstructions. They were not done here in Charlotte. I didn't have the records, but we could kind of figure out it was kind of a bread and butter calcaneal osteotomy, first metatarsal dorsiflexion osteotomy, and Brostrom's. Those did fine for a while. Then he developed progressive ankle arthritis, varus ankle arthritis, incongruent varus ankle arthritis, and then underwent 5 years to him presenting to me, underwent staged, but ultimately bilateral arthroscopic ankle fusions. Done in another facility, and those did well in his words for a while. He didn't have any post-operative problems with any of these surgeries, by his report. Comes to see us here in Charlotte. At this point, he's 5 years out from his ankle fusions. He's having progressive bilateral hindfoot pain. Both sides are equally bad. And you can see this when he walks. He definitely has residual varus. Look at the bottom of his shoes. He's worn out the lateral sides. He's tried orthotics. That hasn't helped. I think I was the third provider he'd seen over the course of probably 6 months. He'd seen actually two colleagues who were fantastic. So he'd gotten some really good opinions and ideas. Through the course of that, he had subtalar injections that provided 100% relief, although they were fairly short acting. And he, at this point, he's tried custom bracing, orthotics, etc. At this point, he just likes wearing all off the shelf lace up braces, particularly when he hunts and when he golfs. He is, as I said, he played basketball, tall guy, 6'5", 215. So his BMI is very reasonable. He's got healed scars bilaterally, very healthy soft tissue envelopes. A little hard to tell whether the varus was from his heel or from his ankle. You know, we're all used to these cases where it's just a little hard to separate the two, even with good imaging. I thought that his ankles were fused in some residual varus, and then under that, he had another 10 to 15 degrees of heel varus based on clinical exam and supported by imaging, which I'll show you. As you can imagine, really stiff hind feet. I mean, his subtalar joints were almost locked in varus, very tender along the sinus tarsi, consistent with his subtalar problems. You know, he'd had at least the first metatarsal osteotomies prior, and I thought his foot otherwise looked pretty reasonable. I thought really most of the deformity was hindfoot and then some from the ankle. Here's his imaging. So bilateral standing ankle x-rays, as I'd mentioned earlier, and had undergone arthroscopic ankle fusions, large cannulated screw fixation. Fibras were spared, of course. And the fusions look great here. It's kind of hard to tell if the position of the fusions. I thought the clinical exam was a little bit easier. I think you could certainly appreciate that at the distal part of the imaging that he's definitely in varus, at least below the ankle fusions. Here's a lateral of the left solid fusion, a little bit of cavus. I didn't think it was honestly too bad, at least on the lateral weight-bearing x-ray. We got standing CT scans, which are so helpful for cases like this, at least for me, especially for the deformity analysis. I'll zip through the sagitals here. Of course, you see the solid ankle fusion, end-stage ankle arthritis, no surprise there. A little bit of TN arthritis as well, which is a bit worrisome, but his symptoms seem to be entirely from his subtalar joints. And here's the coronal. I'll pause it here. And you can see how much varus. His heel is in there. Subtalar joints in a bit of varus. I felt like it's a bit hard to tell because his ankle fusion is so well consolidated, but I did think he had some varus through his ankle based on this CT scan. So problem list: healthy gentleman with end-stage subtalar arthritis under what I thought were malunited ankle fusions and reasonable foot alignment. He has, as I said, he'd gotten some other opinions. Clearly, the pain's coming from his subtalar joints, but he's got alignment issues as well. And we kind of went through, and at this point, he's ready to do something. And we kind of went through the list of options. One was just do a subtalar fusion alone under the ankle fusion and correct as much of the varus as you can. You know, we all know that there's a much higher non-union rate, subtalar fusion under an ankle, which is kind of another discussion. But that was one option. And I was considering just, if I did that, I'd probably just do big, long cannulated screws alone. Or this was an opinion from a colleague, convert the ankle fusion, especially since he's got bilateral disease, convert the whichever side you want to do first, fusion to a replacement, which will offload his subtalar joint, although it doesn't necessarily correct the deformity. And then you could stage the subtalar fusion if you wanted to, or do it at the same time. And whether you wanted to add distal tibial osteotomy or not, if you thought the ankle was a problem, you could do that, or you could just get your ankle correction with your replacement. So a lot to unpack there, but the general approach with this one is you're going to convert the fusion to replacement and then fix the foot and the subtalar joint in different ways to sort of skin that cat. Number 3, fuse the subtalar joint, which I think obviously you can get at least 10, 15 degrees, maybe more correction through that, and then add an osteotomy at the level of or just above the ankle fusion. And so went through all this with him. I thought it was really down to number 2 or number 3. I didn't think a subtalar fusion alone would. I was worried he'd still be in a lot of varus. I don't personally feel like I get a lot of correction just through subtalar fusion alone. I mean, you can do flat cuts and there's some tricks, but even then, I think it's a hard joint to realign substantially. So I was kind of leaning towards, if I'm going to fuse him, do number 3, because I could take a big wedge out of that solid ankle fusion and really get him over well. In terms of number 2, we talked about it for quite a while. He didn't like the idea of 2 surgeries. Pretty simple guy. I mean, again, hunts and golfs. I thought he's already basically got a TTC fusion as stiff as his hind foot is. So I thought if I could just give this guy pain relief with 1 surgery, he'd be happy. And I also have not had great results with ankle fusion takedowns. I still do them, but I think they do okay, not great. So we were on the same page with this, and so we both kind of decided let's do number 3. So our approach was transfibular, remove the distal fibula for the approach. Through that approach, you're looking right at the distal tibia. You could easily just do a little closing wedge laterally, then dissect more distally, do the subtalar joint prep, flat cuts if you want to add a little more correction, depending on what the in situ prep gives you. Proximal tibial autograft, and then a hind foot fusion nail. I think we probably all aggressively graft our subtalar fusions underneath an ankle fusion just because of the non-union risk. So here, I wish I had better images from surgery, but this is an intraoperative picture. You can see the we've removed the distal fibula, and that's the osteotome across the ankle. We actually used a sagittal saw, but there's the osteotome we put in there to sort of free things up. And where do you cut it and how much bone do you take? Honestly, I just went in kind of the distal metaphyseal area because there's a lot of bone there. It's obviously healthy cancellous, easier to get correction, maybe a higher fusion rate. And I kind of guesstimate the wedge. I don't do any sort of fancy geometrics on that. It usually ends up being, I kind of start with a smaller wedge, and if I need more, take more, and just can go based on kind of clinical judgment. And then, so you can see the flat cut there. This is after we put the rod in, of course. You can see where we did the osteotomy just above the ankle fusion, swung the hind foot over as much as we could, and then used the TTC nail, and then put the fibula back with a couple of screws. And there's our kind of final position. And I did tell him that you still have the opportunity to convert this to an ankle replacement down the road if you ever needed to. I don't think you'll need that, but with the fibular sparing technique and everything else we've done here, you certainly haven't burned any bridges, that was another kind of point that I wanted to make with this case. So there he is, and he was non-weight bearing for 6 weeks, and in a walking boot for 3 to 4 weeks, and then he did great. Here's his probably 6-month post-op x-ray. And then there's the lateral. And of course, getting axial images during surgery and after surgery is very, very helpful, certainly during surgery to assess your realignment. I thought thought we got him. He's still maybe a little varus, but I thought it was a huge improvement. And that's with a distal tibia osteotomy. I think it would have been way, way underpowered if we hadn't done that. And then we ended up doing his other side. So now he's got bilateral TTC fusion. So take home points, obviously, fuse the ankle correct the first time. I think particularly these cases that have like the long-standing cavus foot, and then you get varus ankle arthritis above it. Seems like those are the ones that sometimes we tend to undercorrect and probably should be overcorrected, if anything. I do arthroscopic ankle fusions, but I also do open. I have a low threshold for an open arthrodesis. If there's deformity, I think it's just harder to get good correction arthroscopically. That may have been one hurdle here. I think somebody that does have a malunited ankle fusion, I have a low threshold for realigning it. I don't think it's hard to realign it. And I think they're just very poorly tolerated. I mean, if you fuse somebody in the wrong position, at least my experience has been, it's not, even with orthotics and bracing, it's really hard to get them over the hump if they're not plantar grade. I love hypofusion nails for the subtalar fusion under an ankle fusion. Just think it's sort of better stability and fixation, and it bridges it all. And as I mentioned earlier, if you can save the fibula, just so you can leave an option open for a TAR conversion down the road, if possible. So anyway, that's it. I thought that was an interesting case on what not to do the first time, then how to fix it if it comes your way. And at that point, I'll hop off and I'll turn it back over to you, Aaron. Thank you.
Thanks, Carroll. That's a great case. That's very interesting, very complicated. Thank you for that. All right, we got some questions coming in. I think we'll go over each of the questions at the end of the talks here. So I'll kick it over to David Richardson here and continue on with our talks.
That looked amazing, Carroll. And certainly that was a complicated ankle fusion or TTC fusion without complications from your standpoint. I think it looked good. I agree with you with the arthroscopic part of this. I think you ought to have a really low threshold, not just opening it, but putting a plate. I think there's pretty good literature to suggest that a plate increases their chance of getting a fusion and improves outcomes. By adding a plate, you can add a small anterior plate that are out now without opening them up too much more than that. But I'm pretty quick to open them and very quick to put a plate on as well with that. But I think that looked great. All right, so managing complication ankle fusions. I'm David Richardson, Campbell Clinic. Talk about some of my mistakes, because that's going to be the main part of this talk, or the ways I screwed this up. And so we'll go through this. So 71-year-old draining lateral ankle wound. You can see here has some drainage laterally, serous, maybe even purulent, serous drainage over here. Laterally looked pretty good. So she had a bimalleolar ankle fracture with surgery a year prior. Walked on this, it fell apart on her, and so went back to surgery 2 weeks after the index procedure. Had to have this revised. 5 months, maybe 4 months later, she started having medial and lateral drainage from her ankle, increased markers. Cultures are negative in the physician's office, placed on clindamycin. She bounced along for a while. A few months later, had removed her hardware immediately due to continued drainage, her inability to bear weight. Last seen by the treating physician in October, and then presented to me about a year after her initial injury. This is her x-rays. You can see loose hardware. You can see the ankle joint looks pretty trashed, non-union of the medial mal, and yes, has an intermedullary screw at this point as well. These are non-weight bearing films, which I think matter. She couldn't bear weight, but I do think you need to think through that. In looking at this, I thought her ankle joint looked pretty terrible, but her subtalar joint might at least be reduced, if not be reasonably maintained on this. So she's a half a pack a day smoker for a lot of years, probably more than that. She always smelled like cigarettes. coronary artery disease. Importantly, she had a right total knee in 2012 that became infected and had to be revised 2 months later. Has and done well since. Laminectomy, right ankle surgery that we just talked about. So on exam, she had a draining lateral wound, valgus ankle, good pulses, early peripheral neuropathy, but does have protective sensation, good range of motion of her knee without evidence of pain instability, although again, non-weight bearing or infection. She has intermittent fever up to 102 degrees Fahrenheit, unable to bear weight for 3 months, lives alone. Daughter can help with some activities of daily living. They're not going to live together, and we're pretty clear about that in either direction, daughter living with her or vice versa. So I had to think through that as well. So her markers when she saw me were up, WBC and vitamin D was normal. I got a CAT scan. Some thoughts might have been to get an MRI or a tagged white blood cell scan or a SPECT scan. Didn't think that was going to change how I was going to approach this, so didn't do that. So got a CAT scan. The ankle joint looked pretty terrible. Subtalar joint also looked pretty terrible, but for some reason I sort of chose to ignore that. That I'll regret. But admitted her to the hospital, ID consult, vancomycin empirically per ID, consulted case management for placement. Performed a fibular osteotomy, removed her hardware. You can see no fibula here. I also performed a medial malleolar osteotomy as she still had a wound medially and wanted to decompress her and get bone biopsy and just to breed her on that side as well. So that's January 14th. At that surgery, we placed an antibiotic spacer, cement spacer, vancomycin, and an aminoglycoside. Is that the right antibiotic spacer, or is that the right antibiotic cement construct? I'm not so sure, and we'll talk about that. This is the surgery I performed, and importantly, January 14th, 10 days later, took her back and did this to her. Still has that intermedullary screw because I couldn't figure out how to get it out. At least doing what I was doing, couldn't figure out how to get it out. So this is what I did for her. Is that the right interval? I think we probably know the answer to that. And is that the right construct? And I think most people probably know the answer to that as well. So cultures came back as methicillin sensitive and resistant Staph aureus. Biopsy results showed osteomyelitis of her fibula, but not of her tibia or talus. Admitted to a nursing facility after a few days in the hospital to assist with ADL's ambulation. Placed on vancomycin IV based on sensitivities. Bone stimulator was ordered but denied by insurance because she had not had 90 days to have an established non-union. So came back, 5 months later or so, looking like this, really didn't have much pain, was ambulating. I was fairly pleased with this, but as Carroll Jones has taught us in the past with some of his literature, you really don't know without a CAT scan whether that's a fusion or not. It can look pretty good radiographically, but not necessarily once you get a CT scan. So that certainly looks iffy when you zoom in. It's sort of wondering, but she wasn't hurting and doing pretty well. So we bounced along a little bit. Came back a few months later. Now she is hurting, still weight bearing, but has pain. That's looking even more iffy at this point. Still see that screw. Subtalar joint looks certainly a little worse, a little more unstable there. And so we got in a hindfoot alignment view, released an axial view of her heel, and that certainly looks unstable. Looks like she's an asymmetric valgus, and valgus on the left side too, but significantly asymmetrically valgus on the right side. Obtain a CAT scan, show some avascular changes of her talar body, a non-union of her tibiotalar joint, and significant hindfoot valgus. This is her calcaneal tuberosity, a little tough to see right there, but a significant valgus in her hindfoot. So that was in November. This is her CAT scan that's going to show that same thing. She has a non-union of her ankle joint, seen here, and then this significant instability of her subtalar joint and then dramatic hindfoot valgus. Lab workups were really normal. CT scan we just talked about. The ankle looked all right. She didn't have any draining wound, didn't have a lot of swelling, but she's unable to bear weight. You can see she's in a wheelchair. Obviously, she had bounced along. She wasn't willing to undergo more surgery, and I don't blame her. She had been through a lot. But now she's not able to walk on it. She lives by herself. She's pretty miserable, so wants something else done. So we go in. I do put a guide pin in and ream from the plantarly up through the calc and talus into her tibia so I can get this screw. I do have to make a little cortical window, which I made through the previous screw hole sites. I connected 2 screw holes over here so I could stabilize because I was starting to push that screw up towards her total knee. This did not work, by the way. It's just what I had saved. I had to grab that screw and then put a long kerrison rongeur up once I had it down enough to be able to grab it, and that's how we got it out. Then I put antibiotic beads, which was probably better for her. I increased antibiotic concentration with the beads rather than the spacer, but put these beads in March. Cultures, now just methicillin sensitive Staph aureus for the culture results. Positive biopsy for osteomyelitis of the talus, negative on the tibia, admitted to skilled nursing again. Daptomycin based on sensitivities and referred to a nutritionist, which perhaps should have been done early. So came back in May, this is about 2 months later, and did a tibio-calcaneal fusion essentially. The talus was pretty terrible, sort of fell apart. I do have a little bit of the talar head left, but the body and neck are pretty gone. Used a 5-degree valgus locking plate or 5-degree valgus plate so I could try to get as much fixation in the calcaneus as possible. It's already in a lot of valgus, but I did want to make sure I got good fixation in the calcaneus. So chose this, one of the industry has a valgus nail. So used that valgus nail for a load bearing and load sharing construct. So this is 18 months later or so, 17 months later. She's done very well. Weight bearing is tolerated and ended up healing after being put through a lot more than she probably deserved. So why did she fail? I think that's why you need to ask what you need to ask yourself when these don't go right. So nutrition, she was non-ambulating. She's a smoker. She lives by herself. She's elderly. She's somewhat frail. She almost certainly was malnourished. I did not really work that up. She has osteoporosis. I've been on Fosamax for 3 years. Didn't really work, get her re-examined and see if that might be optimized in any way. I did what we all do. You should stop smoking. Increases your risk, but did not send her for any nicotine supplementation or transition to nicotine, or get her off nicotine. And then she's unable to comply with weight bearing. She had been through multiple rounds of this. A lot of people had tried multiple different ways to tell her not to put weight on this, and she was going to bear weight. And I needed to understand that was going to happen. So understand the chronicity. She had been through a lot, more than she needed to be. It had been a year when she first saw me. She had been through 3 surgeries. I needed to do everything I could to make this the definitive treatment. So I needed to have understood the chronicity of this, that I didn't very well, understood the patient better than I did, understand that I was getting a non-weight bearing physical exam because she could not bear weight, and be careful with that, take a little more time with that, and understanding that I couldn't watch her walk. I couldn't just watch her even stand and get an idea of her alignment that way. And she corrected really well. It's just sitting on the table, but that's on me to recognize that. Surgical construct, maybe beads and then a nail. So I wasn't reaming through a potential area of infection. So perhaps the beads to get rid of the infection in that area first, and then a subsequent nail. And then a load sharing construct might have been better for her. In order of bone stimulator preoperatively, she had a non-union from her fracture side. I probably could have gotten a bone stimulator if I'd done it on the front end, said she had an established non-union of a fracture, could have had that ready for her and used it earlier and not had to wait 90 days for a bone stimulator. So this is the antibiotic that was chosen. I've already shown this. Is the correct antibiotics? Probably. Correct cement construct? Probably not. Is it the right interval? Certainly not. So antibiotic cement, so vancomycin plus an aminoglycoside is probably the right empiric treatment, broad coverage. Aminoglycoside promotes vancomycin release. Ought to leave this in at least 90 days at least 30 days per the literature. Use a cement spacer if you need to go back and do a total knee or total ankle to preserve that soft tissue. But perhaps beads would be better. The elucidation of the antibiotic, how it leaches out of the cement is based on surface area. So if you have beads, they're going to leach a lot more of the antibiotic, and that's been shown in plenty of literature, more so than a large spacer is going to. And that's probably what she needed, is high concentration of antibiotics. And people have asked, why not just do both? You got to be really careful about that, because the first 24 hours, these antibiotic cement has a significant spike in the amount of antibiotics, and so they can get toxic and locally or systemically. So be careful about that. Literature to say that either way, they probably maintain the minimal inhibitory concentration for up to 4 months, but for her, I think probably beads would have been better. This construct probably should have incorporated the subtalar joint right off the bat. I should have incorporated the subtalar joint off the bat and used a load sharing device. So what I should have done, the hardware, except perhaps that IM screw right off the bat, so I'm not reaming up through an area of infection. She has a total knee above her. I was very worried about infecting her knee. She had already had an infection, had it revised. She's a smoker. I was just concerned about that. So maybe leave the IM screw, but do this construct right off the bat, and leave it in for at least 30 days. Then perhaps come back at 30 days, then put in an intermedullary antibiotic cement nail, as shown here. This is one of Dr. Ryder and Dr. Rudloff. They're both my partners, and I think this technique was described by my previous partner, Dr. Perez, just to give everybody their due here. But probably should have done this, come back and done that, and then put in this load, this construct, to give her a chance to maybe put some weight on it and have her last surgery first. Key takeaways: review notes prior to visit. This is not someone that I could have figured out in 15 minutes. The 15-minute patient visit. I looked over it beforehand, but it was a ton of notes, and I did not take my time to really know her prior to her visit. Slow down when it feels complicated. This certainly felt complicated. I just needed to take more time. If it's a non-union, if it comes to you, then consider a bone stimulator. Obviously, if it's your patient, you might have already gotten a bone stimulator by this time, but if it comes to you as a non-union, consider going and ordering a bone stimulator before you get them set up for surgery. Careful physical exam, especially if they can't bear weight. Consult those who need to be consulted, and communicate with them. Call them beforehand. Get everything set up. Be sure they're going to get in to see these folks in a timely manner. Let them know this is a complicated patient, as we just talked about, so talk it through with them. ID consult, a nutritionist would be helpful. I just said a family nurse practitioner because that's what we have here. We actually have two who help us with perioperative optimization, are very good with this. I actually primarily work in a satellite clinic, so they fall off my radar in a way that they shouldn't at times. Consult the case manager for placement early. If it's staged due to infection, consider your cement construct, the type of antibiotic and dosing you're going to use, and the interval, and talk through that with the patient so they're prepared. Consider patient's social situation, ability to maintain weight-bearing status. When you have a complication, draw these patients close. This is the time to let them know you're going to be there, you're going to get through this together, you care about them. As one of my mentors would say, love them up. Just be sure that they know you're with them. Any patient with a complication, gets my cell phone number right off the bat. My assistant knows to give that to them. As soon as they have a complication, they have my cell phone. Some of you may do that with everyone, but I do it certainly with complications. And so love them up. This is, a lot of you guys might know my father, and so I was going to put that on. It is a few days ago at a service event we were doing. He's the one that taught me to love this specialty. So my mom and dad came and stopped by. So there he is. All right, thank you.
All right, thank you, David. That was a great case. It's I'm still wondering how that screw got up there in the intramedullary canal. That's I don't think I've ever seen that, but that's very interesting. So, but thank you. That's a very very complicated case and brings out a lot of the points that we're trying to make here of evaluating your patients, considering all the factors when we're going through a complicated surgery like this for treating them and as well as treating the complications. So lastly, I'm going to try to pull up Eddie Haupt is not able to be with us. He's I have another commitment, but he has a talk that he's put together. I'm going to try to run that video now. See if I can bring that up here.
Hello, my name is Eddie Haupt. I'm a foot and ankle orthopedic surgeon at the Mayo Clinic in Jacksonville, Florida. I'm going to talk about some ankle fusion complications. This one's specifically about avascular necrosis from COVID-19 treatment. First about me, I'm actually from Central Florida. I'm from a place called Merritt Island, Florida, which is right next to Cape Canaveral. I think the notable things about that area is it's a beautiful place, but almost everywhere, the space industry or NASA or the cruise ship industry. I went on a football scholarship at the University of Florida. We were very successful in that period of time. This is from the first of 2 national championships when I was there. I stayed there at the University of Florida for medical school. I was a resident there as well. And, classic Florida man here, Heismaning with an alligator. When I was there, I was very blessed. I got married. I had 3 little girls. I couldn't do this without them for sure. We went to California for fellowship for foot and ankle training at Cedars-Sinai Medical Center. It's a wonderful program. Very grateful to have trained there. And now I'm back in Florida. I'm in Jacksonville now, though, and I'm at the Mayo Clinic in Jacksonville, where I've been in practice since fellowship. So happy to be here. Here's my disclosures. I think nothing pertinent to this. And then here's our objectives. We'll talk about complications in ankle arthrodesis, some challenges of avascular necrosis, and some diagnosis of complications of ankle fusion. We're going to really frame this all with one case. I have a 59-year-old female. She has a history of rheumatoid arthritis. She takes a biologic called Orencia, which impairs T-cell activation. Her BMI is 29. She does have a history of very well-controlled diabetes and takes a GLP-1 agonist, but otherwise no insulin. A1C is less than 6. She has high blood pressure and high cholesterol. She was doing fine until February 2022 when she got COVID. When she had COVID-19, she was in the ICU for 3 weeks. She was getting high-dose steroids and high-flow oxygen while she was intubated. 6 months after that, she noted that she had severe ankle pain, and radiographs identified avascular necrosis affecting the distal tibia and the talus that eventually went on to collapse. And so just to follow her x-rays is pretty interesting. So here, this is like right around shortly thereafter, the high-dose steroids for COVID, and clearly she has what looks like an area of hyperdensity in the tibia. I don't think the ankle joint there looks very collapsed. As time goes on, 2 months after that, she pretty rapidly collapses. There's like a lesion noted there on a lateral radiograph. You can see the large zone of AVN, and as time goes on, she even develops a Codman triangle up here in the distal tibia, so having some insufficiency fractures and collapse of the tibia, which is a little bit more uncommon than it is within the talus. Here's an MRI showing that lesion, loss of cartilage, and some collapse. So she fails non-op management. Her local surgeon treats her non-operatively appropriately for several months. She ultimately ends up getting an ankle fusion with an anterior approach, anterior plate, June 2023. At the time of the surgery, they performed a proximal tibia autograft bone harvest to supplement this area of avascular necrosis, and they used an anterior plate with a interface screw. She had an uneventful recovery. She was adherent to all precautions from her surgeon. At the 3-month mark, she was still noting significant pain with the ankle. She said that has told me since that she never reported any improvement. She can't walk, and she also notes a new pain at the medial proximal tibia with radiation down at the site of the graft harvest. 3 months after, she tells her surgeon this, it's documented in the notes. I talked to her, she may just be having a prolonged clinical recovery at 6 months. She notes the same symptoms. The local surgeon got a CT, which was read as healed by the radiologist. So here's some cuts from that CT. And there are areas where you can see some of the joint line, but there are other areas where it looks like there maybe is some consolidation across. So not a perfect looking CT, but also not one that looks overly concerning for non-union. I think in some of these, hindsight being 2020, it looks to me like it's probably not healed, but nonetheless, it'd be hard to say it jumps off. On that same CT scan, you can see the ankle a little bit there at the bottom of the screen with some worrisome looking cuts. There's this area where the patient had a proximal tibia graft harvest. The radiologist down there read it as a possible tibial mass, and I think nobody ever talked to the foot and ankle surgeon because she got referred here for a bone tumor, which is how she became my patient. So nonetheless, that was just an area they backfilled after a proximal tibia graft harvest. There was not a tumor there. Anyways, when I saw her about almost a year after the index surgery, she can't walk because she can't get her foot flat on the ground. She's pain at the ankle. She has pain at the most proximal edge of the plate. And so the worst pain is at the ankle. Second worst, actually, the proximal edge of the anterior plate. And then the third worst is at the proximal tibia at the side of the graft harvest. So these are the things that I was thinking about. So as far as that not being able to get your foot flat, is that just because it hurts, or is that because you're fused in equinus? That'd be the main thing I'd be worried about there. The proximal tibia graft site, it seems to radiate down the leg. That to me seems like it's a nerve issue. Proximal edge of the plate. There have been descriptions of stress related to the plate, and then we want to know if there's a non-union. So I think that watching her, without getting any scan, gig exam, she dorsiflexes to 0, not enough for the neck fusion. And when she attempts to walk, there is no tibial progression at all with a progression angle, which again, that could be due to pain, but it could also be that she's mechanically not able to, she's at her maximum dorsiflex enough. As a portion of the planning for surgery, we did get a standing CT scan. And so if you draw between the tibia to the floor, it's 83.5 degrees. And so I think most people would be going for about 5 degrees dorsiflex. And so radiographically, this looks good, and so, however, you could ask the question, is it too equinus for her? And I think there's some other cuts that I've showed where you can see that her forefoot's significantly cavus. So maybe that's what it was, but I can't say that I would critique the surgeon here much at all. The saphenous nerve symptoms, I had arranged an image-guided saphenous nerve injection. She got complete relief of the medial pain. So something is up with the saphenous nerve at the proximal tibia graft harvest. Here's the options I have for that. You don't have to do anything. You could just observe. Maybe an option to.
Hey.
Hey, guys. Hey. Just wanted to let you know we got to cut it off. I'm sorry. We got to get the other session started.
Oh, thanks, Selene. That's thanks to all you guys for participating. This was a great session, and thanks a lot for asking us, Selene.